And we're going to start now and talk about obstructive diseases. Now, you already know a little bit about the obstructive diseases. We talked about these diseases that on the pulmonary function test, their airways collapse. And what happens when their airways collapse? Well, they obstruct the airflow, right, usually on expiration. And that's when you get the big hyperinflated lungs, the flattened diaphragmatic surfaces, right, and the wheezing that we sometimes hear. The wheezing is, you know, the patient trying to expel air out of the lung, and that's what we see on the X-ray, the flattened diaphragmatic surfaces and the hyperinflated lungs that are so consistent with these diseases. There's 3 diseases that we basically need to know about. It's the most important ones are COPD, the 2 COPD types, emphysema and chronic bronchitis, and asthma. And then we need to know a little bit about bronchiectasis. So let's look at those cases here. The first case is a 26-year-old woman with history of asthma who presents to the emergency department with 3 days of progressive shortness of breath. She takes inhaled albuterol and over-the-counter cold medication. Now, let me tell you a little bit about this. This is an important thing here. Now, this over-the-counter cold medication she took just the last day, right? And she noticed that even though that you know she had her shortness of breath, the last day or so things were getting even worse. When you see her respiratory rate is 28, her pulse is 110, she's afebrile. Her right nasal turbinate is edematous. There is evidence of wheezing throughout both of the lungs. After you give her supplemental oxygen, that's the first thing we do, what should we do next? So that's an important question. The answer is, you're going to see a little bit later, what do we do after we give the patient supplemental oxygen? We give the patient a bronchodilator. What's the best way to you know, resolve the bronchoconstriction that a patient with asthma has is to give them short-acting bronchodilators. So the answer here would be to give the patient albuterol to resolve the bronchoconstriction. So a couple things on this patient, and then we'll talk about asthma and virtually go back to this case. Now, a couple things. When I evaluate a patient with asthma, what I want to know is what their prior history is. How many times they've went to the hospital, if they've ever been intubated. That gives me an idea of the severity of her asthma. And then I want to know, did she take any medications that may have exacerbated asthma, because this falls into a very specific category of asthma. Patients that have nasal polyposis and also have some sensitivity to aspirin, and there's cross-reactivity of aspirin with nonsteroidal. So about 20% of these patients also have cross-reactivity with nonsteroidal anti-inflammatory medications. But these patients generally have nasal polyposis, they have sensitivities to aspirin, some of them have sensitivity to NSAIDs, and they develop severe asthma. So I want to know that. And this patient, when she told me that, yeah, I took over-the-counter cold medication, and then, you know something, after I took it, you know, my asthma got worse, and then I find this here, the edematous turbinate, right, nasal turbinate, I start to think maybe she's got the syndrome here, and these people have severe exacerbations. So that tells me, you know, that this patient's not going to be easy. Then a couple of other things. I want to know from the exam, is she having a severe attack? And there's a couple of things that tell me that. Cyanosis, muscle retraction, right, from the exam. You know, silent lung, where you don't hear any wheezing at all. Those are bad signs that this patient's really having a severe exacerbation. And then we're going to talk about some lab findings like hypercapnia that we just talked about also just before, and went to intubate and admit a patient to the ICU, that also mean a bad prognosis for asthma patients. But the first thing I do always in an asthma patient is I give them oxygen, and then after that we give them bronchodilators. The short-acting beta agonists like albuterol are the first-line drugs in the acute exacerbation in asthma patients. So the anticholinergics don't work so well. They don't work so well because they're long-acting. You don't get that short, you know, that short-acting stuff that you get with albuterol. They're better with COPD patients. Aminophylline, right, we don't do anymore. unless the patient has status asthmaticus. Epinephrine and stuff like that, we don't do anymore. It's only with the most severe status asthmaticus that most of these cases, they're very rare now because we're able to treat the patient quickly with some other stuff that we're going to talk about with the albuterol, with the steroids. We don't have to use this medication. So traditionally, I know people have been using those in the past, and you read about them and you hear about using them, that they still use them in other countries, but we don't do stuff like that here. It's usually a beta agonist that we use, supplemental oxygen, and some of the steroids that we're going to use, and we'll talk about that stuff right now. So let's talk about general concepts about asthma. So asthma, the basic issue with asthma is it's an inflammatory process. The patient's lungs are hyperactive to some type of either allergens or infections, or sometimes we don't even know the causative organism or scenario, but these patients have hyperactivity more than normal people, and there's an inflammatory process that occurs. It's very important that you understand it's an inflammatory process, because the way you treat asthma, treat it, cure it basically, in a way, on a chronic basis, is through giving the patient anti-inflammatory drugs. So for example, we talked about before, what's the first thing that you do in a patient with an acute exacerbation? You give them bronchodilators. Yes, because the patient is very hypoxemic and is having distress, but that doesn't take care of what the disease is itself, and that it is inflammatory disease, and you have to give this patient anti-inflammatory medication to resolve that. It's always reversible. Asthma is always reversible. That is that's how you diagnose asthma, because on the pulmonary function test, in order for you to tell somebody they have asthma and to tell another physician that this patient has asthma, you're going to have to prove to them that they have a reversible disease, compared to chronic obstructive lung disease, where these patients, there's no reversibility, or that reversibility is very small. So, and how do you prove that reversibility? Well, one is the pulmonary function test. You give them bronchodilators and they reverse on the pulmonary function test. And then the other one is the history. The patient with asthma gives you exacerbations, and then in between, they feel great. They have no symptoms at all. In fact, they could have a total normal pulmonary function test in between the exacerbations. That's not the case with chronic obstructive lung disease. Patients with chronic obstructive lung disease have a baseline symptoms, and then when they have an exacerbation, they get worse. So these patients tell you, yeah, I'm always short of breath, I can't walk, I get short of breath, and then, yeah, the last couple of days I got worse after I got an upper respiratory tract infection. That's the type of history you get from COPD. Asthma, the typical asthma patient, is asymptomatic in between. The typical one. Not everybody, but the typical one. So the other thing that we see is that we usually get a history in asthma of early onset. So most of the cases that we see, usually they have the onset when they're children. And then, you know, it goes into adulthood. Now, you may hear this concept that a lot of patients, they get childhood asthma, and then a good % of them, maybe about 2/3 of the cases, they kind of outgrow their asthma. That's what people refer to. It's not really what they do, but basically, as they get older, most people get better. Childhood asthma in general is a better asthma just because more patients they get better as time goes by. The people that have adult asthma, these patients usually are the patients that didn't outgrow their asthma, so they still have it into adulthood. So generally speaking, if you take all patients across the board, people with adult asthma usually have a more severe, you're more likely to have a severe asthma when you compare it to childhood asthma. I'm not talking about individual cases, I'm talking about across the board. Having said that, asthma could be new onset at any age. Yes, most of the cases usually occur in childhood, and then you get a history that goes into adulthood, but cases have been diagnosed of clear-cut asthma in their 4th, 5th, and 6th decade of life. So You could have new onset asthma at any age group. It's usually early, but you could have it even later in life. And when this occurs, most of these patients have a more severe form of asthma than the ones that usually get it and have it through from children to adulthood. There's two types of asthma that we hear a lot about, but usually in the long run it doesn't really matter a lot. We hear about this atopic extrinsic asthma, that people get asthma exacerbations to different allergens in the environment. These are the patients that usually have urticaria, usually have other allergy symptoms, so this is referred to as extrinsic asthma. This has a better prognosis versus the idiosyncratic asthma, the intrinsic asthma, that basically there is no specific reason that these patients get exacerbation. I mean, they could get a viral infection or pneumonia, and that worsens asthma, but generally there's no specific reason that if these people, come close to some kind of allergen, that this will precipitate asthma. The idiosyncratic asthma, the intrinsic asthma, is more severe than the atopic asthma, generally speaking. Now, a lot of our patients, that's why this breakdown into idiosyncratic versus extrinsic asthma, it has fallen a little bit out of favor, just because in all our patients we look for allergens, we look for other things. Most of our patients have a little bit of both. They have a little bit of idiosyncratic asthma where we don't know what exacerbated their asthma in a given occasion, and then if you look closely, they have a little bit of extrinsic asthma. So, for example, if they come close to some, allergens like, animal hair and stuff like that, this precipitates their asthma. So most patients have a little bit of both. The breakdown is not 100% makes clinical sense. They have asked us a lot of times, what are the most common precipitants of an asthma exacerbation? So the most common one across the board are lung infections. And what are the most common lung infections? The most common ones are viral infections. So it's more common to see asthma exacerbation in the winter time and a time of the year where people get viral infections and lung infections and so forth. Then the second ones that we hear about are drugs. Please be careful about aspirin and nonsteroidal anti-inflammatory medications, because I told you about the syndrome that they have nasal polyposis. That's what this patient had, and had sensitivity to aspirin, and some of these patients have sensitivity to nonsteroidals. Please be careful of that. Always get that from the history. And they may ask us, what are some of the drugs we don't want asthma patients to be taking? The answer is, I don't tell them to take aspirin. I tell them to keep away from NSAIDs in case they have the syndrome and we don't know about it. And then the typical one is the beta blockers. You hear a lot about that. And it's not an absolute contraindication to use a beta blocker in an asthmatic patient, but you have to be careful. You have to be careful, because no matter how cardio-specific the beta blocker is, they still cause some bronchoconstriction in these patients. So if you're going to use them for blood pressure control or heart failure management, be careful, because the patient may tell you, listen, I have more shortness of breath now, and it's not from the heart failure. Now it's because they have their asthma is worse and stuff like that. And then the third one that's also very important is exercise induced, right? So when you exercise, especially out in the cold, it causes bronchoconstriction. It causes bronchoconstriction actually in normal patients, but these patients, remember, they have hyperreactivity. And now they get, asthmatic attacks when they exercise. They tell you, I run a couple miles, and after I run, I'm coughing for 20 minutes. Or I go out in the cold, and I start wheezing, and I start coughing. So that's what they're talking about. They have to be a little careful. There's ways to manage these patients by giving them bronchodilators. We're going to talk about that in a little bit. So that's your general concepts. And let's talk a little bit about the presentation of these patients. So what's the presentation? When they have acute exacerbation, we're talking about the acute exacerbation, they develop tachypnea, of course, they're breathing quick, you're going to hear wheezing. Sometimes you don't even have to listen to their lungs, you can hear them wheezing, from a couple feet away. Sometimes if the asthma exacerbation is severe, they develop accessory muscle use, so they're hunched over, and you could see the use of the accessory muscles. They have diminished breath sounds. That's usually not a good sign, because that if you develop totally diminished sounds, that's a silent lung. And some people say, okay, the patient's not wheezing, but they're not having any air movement in and out of their lung. That's a reason to watch that patient closely in case they need intubation. And then along with that, intercostal retractions and diaphoresis. These are all signs that this is a severe exacerbation. A paradoxical pulse is very interesting, because a paradoxical pulse is normal in all of us. That dip in the blood pressure is normal, and if you have less than 10 of paradoxical pulses, okay, but a pulsus paradoxus in patients with an asthma exacerbation, especially over 20, it means that this is a severe exacerbation. So right away, a couple of things that you should know from this slide that tell us that this is an acute exacerbation: accessory muscle use, diminished breath sounds and silent lung, intercostal retraction, diaphoresis, and a pulsus paradoxicus of over 20. All these are ominous signs. You have to watch that patient closely, because this patient has a severe asthma exacerbation. And then in the chronic setting, now remember, in the chronic setting, these patients could have, if you're treating them well and they have mild or moderate forms of asthma, they could be totally asymptomatic. They could have no symptoms at all, right? Until they come in with the exacerbation. But they may tell us a couple things about atypical presentations in the chronic setting of asthma. They love to ask about these two cases. One is a young patient that presents with nocturnal cough. So there's this type of asthma that presents only with nocturnal cough. It's sometimes referred to as cough variant asthma. So these patients, basically, they wake up in the middle of the night, they cough, and then after a while it goes away and they go back to sleep. For some reason, the exacerbation of asthma seems to occur at night. There's a couple of theories about that, but we don't need to know them for the boards. But it seems that these patients have more hyperreactivity at night. They go to sleep, they develop this cough, they may have some wheezing, but they don't know what wheezing is, so they don't describe that to you. And they tell you in the daytime they feel good. So nocturnal cough variant asthma, I want you to think about that next time you're evaluating a patient with nocturnal cough. So think about postnasal drip, think about reflux disease, but please also think about asthma in these patients. If there's a question about which one of these it is, do a pulmonary function test and confirm the diagnosis. And then the second one, which we already have hinted a little bit about, is this thing called exercise-induced asthma, where some patients come and tell you, I'm coughing after I exercise, and what do you think about? Well, you think about this thing called exercise-induced asthma. Remember, with exercise, you become more hyperreactive, so these patients have a mini asthmatic attack, and they tell you, I'm coughing, and sometimes they tell you I'm wheezing. Some of the patients, though, don't know what wheezing is. So they tell you, I feel some lung congestion, I cough a lot, and then it goes away. And then when they come to your office, they're pretty much fine. They don't have any symptoms at all. So those are the presentations I need you to remember for the boards. Now, how do we evaluate these patients? Well, it depends what you're looking at. If you're looking at like the patient that we were just talking about, the case that we just talked about, in the acute setting, the evaluation is pretty straightforward. The ABG is very important because it gives us an assessment of the hypoxemia in this patient, and it also identifies patients that develop respiratory compromise and respiratory muscle fatigue, because it shows respiratory acidosis, so a drop in the pH, and an elevation in the PCO2. That's why you're really doing the ABG in an asthmatic patient, to see if this patient has hypercapnia, if the patient has respiratory acidosis. All those patients, if they do develop that, if they do have that, have to be in the intensive care unit and monitored very closely in case they need intubation. The typical ABG is one that shows, in an asthmatic patient, the typical ABG in an asthma exacerbation is one that shows respiratory alkalosis. Remember, they're breathing really fast, healthy patients breathing really fast, so they blow off their CO2, so they have hypocapnia, low CO2, and because of that they develop a respiratory alkalosis. That's the typical finding. If you got that, you're okay. But if you develop hypercapnia, please be careful. The chest x-ray in the acute exacerbation, they may ask us about that. Why do we need a chest x-ray in the acute exacerbation? Not to diagnose asthma. Most of the patients presenting with asthma exacerbation, they don't need a chest x-ray to confirm that they have asthma. What do you need a chest x-ray for? Well, remember what the most common causes are of asthma exacerbation? Lung infections. So the chest x-ray is there not to find the flattened diaphragms, the hyperinflated lungs, because you probably know about it already. You don't need that for that, but to see, to make sure that this patient doesn't have some kind of infection in the lung, like a bacterial pneumonia. So, for example, the patient coming in with an asthma exacerbation, I'm doing that x-ray, I don't want to see an infiltrate there because I'm going to have to add antibiotics in this patient to cover for bacterial pneumonia if I see one. The third one is a pulse oximeter. Now, the pulse oximeter is usually, it doesn't give you the PaO2, but it gives us that part, the oxygenated part of hemoglobin, and it allows us to monitor oxygenation, not as definitively as the ABG does, right, but on a continuous basis. So, you can't do ABGs all the time. Remember, you have to do arterial sticks, and they hurt the patient and so forth. So you don't want to do that all the time. You want to do one, maybe do one, a couple of days later to make sure the patient's okay, but you don't want to do that frequently. How do you monitor, the oxygenation in a patient, from hour to hour, is to put the pulse oximeter on this patient and watch that. Now, it has some limitations. It gives you a percent. It gives you a percent. So you correlate that with a PaO2 that is not, specific. It's about. So, for example, somebody that has a pulse oximeter of 95%, I know their PaO2 is about 70, 80. It's not below that. Anything below a pulse ox of below 90, you have to be very careful, because that patient's PaO2 now is 60 or less. You have to be careful about that patient. That means that patient has severe hypoxemia. It also allows me to see what I could do with the medication. So if a patient comes in and has a pulse oximeter of 90%, and I give him bronchodilators, I give him the steroids and stuff like that, well, 2 hours later, I check the pulse oximeter again. Now the patient's at 95, 96% saturation. I know they're getting better with the medication, and I know I'm on safe grounds. So that summarizes the acute exacerbation, the evaluation in the acute exacerbation, like the case that we just presented. But in the outpatient setting, in the chronic phase, when the patient has minimal symptoms or sometimes is totally asymptomatic, that evaluation changes. The focus is different. The first focus is to confirm the diagnosis of asthma. That's the most important thing. Please be careful when they tell you about a young patient that has wheezing and has episodic wheezing and cough. Please don't assume always it's asthma. I've seen recent cases of patients that are young being diagnosed and carrying the diagnosis of asthma, and then we find out years later that they really have something else like COPD. And they had rare forms of COPD that start early in life, like alpha-1 antitrypsin deficiency and so forth. So please, every patient that has asthma and carries the diagnosis of asthma, you have to go back in their history and make sure everybody has had a pulmonary function test and confirm the diagnosis of asthma. What does diagnosis confirmed by pulmonary function test mean? It means that you have an obstructive pattern. The DLCO is normal because it's not like emphysema where there's something wrong with the alveolar membrane. And when you give that patient bronchodilator, you get a resolvement of the drop in the FEV1 over FVC in the obstructive pattern. So improvement after bronchodilator is the distinctive finding in the pulmonary function test with asthma. We also talked about before, and I want to make sure everybody understands here, that sometimes in a patient that has asthma, remember we said they could have a totally asymptomatic pulmonary function test because this is a reversible disease. By definition, it's reversible. It may be 100% reversible. So the patient comes in, does the pulmonary function test, everything is normal. The FEV1 over FVC is normal. The FEF 25/75 is normal. So what do? You challenge him. You bronchoprovocative. You do a bronchoprovocative test in this patient to basically cause a mini asthmatic exacerbation. And this test is called the methacholine challenge test, where you give the patient methacholine challenge and you see a drop in FEV1 over FVC and a drop in FEF 25. That confirms the diagnosis of asthma. Sometimes in the chronic evaluation, people look for other things like elevated IgE levels, like peripheral eosinophilia. The reason I have these 3 and 4 and I have a question mark after that is because they really don't mean that much in terms of the diagnosis of the disease and what we do for this patient afterwards. So really the only thing I want to know in an asthmatic patient is the history. I want to know how many times he's been to the hospital, she's been to the hospital, if they've ever been intubated, what medications they're taking, so you get a sense of the severity of the disease, and I want to know the pulmonary function test that they've confirmed the diagnosis of asthma before I go any further. So the treatment, well, what do we do? Well, in the acute exacerbation, we already know a couple of things about our patient. What do we do with this person? We slapped on the oxygen right away, right? Because every hypoxemic patient, we give the oxygen right away. And then we put the patient on beta agonists. Short-acting beta agonists, I told you, is probably the best way to get to reverse the bronchial constriction. Albuterol is probably the single best agent in this case. There's other ones, short-acting beta agonists. You're free to use any one of those. Albuterol is probably across the board the mostly used and probably the best studied agent. We can give them in one of 2 forms, either as a meter dose inhaler or as a nebulizer treatment. So, you know, the nebulizers they put in their mouth and you put the oxygen and it goes into their lungs, so all they have to do is just breathe. And for a sick patient, a really sick patient, who's really hypoxemic and really tired, a nebulizer seems to be a very good option. A meter dose inhaler, those are those little puffers that they use, and they use a spacer with them. You could get the same amount of a bronchodilator with those as with a nebulizer treatment. So studies have shown that in the acute setting, whether you use a meter dose inhaler, MDI, meter dose inhaler, or a nebulizer, those are equivalent in terms of efficacy. The reason why we like to use the nebulizer treatment in the hospitals is because sometimes the patients are very sick, they're very tired, so with the nebulizer all they have to do is just breathe in, and this takes the oxygen down, the bronchodilator down to their lungs, and it's easy for them to do it rather than taking these big puffs with the meter dose inhalers. But I want to make sure you understand that they're equivalent. So whatever combination you use of those or one or the other, they're equivalent. Some people, the nebulizers, they try to shy away from them as much as they can because they're respiratory tech dependent. So the respiratory tech has to go give the nebulizer. So they get, you know, they're involved with another case, and they, instead of giving it every Q4 hours or Q2 hours, they give it every 4 hours or Q8 hours. So, you know, that's why you need to know that they could actually use the meter dose inhaler and get actually the same results. The anticholinergics are second-line bronchodilators. Some people, especially in the acute setting, will give both anticholinergics like ipratropium and beta agonists at the same time. It's okay to do that, but they're less effective. Generally, they're less effective because they're long-acting. They're long-acting, and you don't get that quick relief effect. They're long-acting, and they take a long time to get into their maximum response. What you want with the asthmatic patient is you want action right away, and that's what you get with the short-acting beta agonist. So anticholinergics are good bronchodilators. We use them less in asthma exacerbations because they're longer to kick in, and they're longer acting. They work better in patients with COPD, where we don't need that quick effect stuff. The patients with COPD have chronic symptoms. So here, as a bronchodilator, anticholinergics take a second step to beta agonists in terms of management of asthma. You could use them together, but they're less effective. The fourth one, and this is probably one of the most important things that you're going to do, and I say number 4 because it's after you do the first two things here. The steroid spurt, right, is the most important thing in resolving this patient's asthma exacerbation. Remember, this patient has an inflammatory condition. And how do we treat an inflammatory condition? One of the ways that we treat it is to give the patient corticosteroids. So in these patients, you give them oxygen right away, you give them beta agonists to resolve the bronchoconstriction, and the third thing you do right away, you don't wait at all, is to give the patient the steroid spurt. A steroid spurt, I'm using the word spurt, is to tell you that you give the patient about 10 to 14 days of a dose of steroids, and you taper it off during that time. So for example, I'm going to start this patient on a high dose, methylprednisolone or prednisone, let's say prednisone 60 milligrams a day, and then over the next 10 to 14 days, I'm going to taper it down to 5 milligrams or so, and then take them off the medication. That's what I mean by a spurt. Some people say, just give them 7 days, high dose, and then stop it. That's also has been used. But generally speaking, you could do one or the other, but generally speaking, you have to know that this is just for a short time, 10 to 14 days, maybe 7 days if the patient gets really better really quick. And then after that, the patient goes back to their normal medication, just to relief of the inflammation, and then we take them off the steroid spurt. If they ask us what's more important in a patient with acute exacerbation, is it the steroids or the beta agonists? And the answer is depends on what they're asking. If they're talking about what do we do next in somebody who has hypoxemia and has difficulty breathing, well, the steroids take anywhere from 12 to 24 hours to see an effect. So the steroids ain't going to help at that time. It's only the beta agonists. If they're asking us, how are we going to get this patient out of this state? They're talking about the exacerbation of asthma. How are we going to get them out of this inflammatory state? The answer is the steroids. After you resolve the bronchoconstriction, you got to get that patient out of the exacerbation, and you could only do that with a steroid spurt. So please watch what they're asking you for, because they're both the right medications to use immediately. The question is, what are you doing for what? Make sure you understand that. The beta agonists don't resolve the inflammation. Asthma is an inflammatory process. So make sure you understand that. Chronic treatment, now we got 2 drugs in the chronic treatment. 80% of the patients with asthma take 2 drugs. They take a combination of inhaled steroids, now as a metered dose inhaler, right, just like the beta agonist, and they take that daily. Why do they take that daily? Because what is asthma? It's an inflammatory disease. So what are you doing by giving the patient inhaled steroids every day? You're treating the inflammatory disease. What is the most important medication in the chronic treatment of asthma? The answer is inhaled steroids. Why? Because they have to take that every day in order to reduce the chance and diminish the asthma exacerbations. That is the most important. That's the most important drug, and that's why it's number 1 here. Now, on top of that, even if they take their asthma, their inhaled steroids every day, they still get bronchoconstriction. And then what do you have? What do you give them along with the steroids? And on an as needed basis, you give them the beta agonist. Usually, short-acting beta agonists work best. So, 70–80% of asthma patients are taking every day, daily. It's important that you understand that, daily. What's the medication that they take daily? It's right here. Inhaled steroids. They take the metered dose Beta agonists as needed. People that have moderate to severe asthma, they have to take the beta agonist almost every day. Some other people with, less, severe asthma, they use the inhaled steroids every day, and maybe they use the beta agonist once or twice a week or so for. So if you could get them on a good steroid dose, inhaled steroid dose, that's the main treatment. The beta agonists are only for breakthrough bronchoconstriction. I hope everybody understands that. One of the reasons why inhaled steroids, people stop using them, is a couple of things, and they're great medications, and but they cause a couple of side effects. One of them is the oral candidiasis that sometimes they cause. So thrush, that's one thing, and patients hate it and they stop using it. And then the second thing is the nasty taste that you get after you use an inhaled steroid. Very nasty taste, and the patients don't like that either. So what do you tell them to do after they use the meter dose inhaled steroids? Is to tell them to wash their mouth out with a little bit of water, right? And that takes care of the thrush. It takes care of most of the time of the bad taste also. You also see in the market now the new meter dosed inhalers with the turbo inhalers, right? There's a lot of them out there now. The turbo inhalers, the patient takes it, and the turbo inhaler makes the inhaled medication go all the way down to the lungs. The patient doesn't even feel that they're taking them. So this turbo inhaler enhances the movement of the medication all the way down to their lungs, so they get nothing in their mouth. They don't get any thrush. They don't get any nasty taste. In fact, when I use it, my patients say, "Hey, are you sure I'm getting this medication? Because I don't feel anything." Versus the old meter dose inhalers, because they would feel it in their mouth. They would know it's working because they would feel it in their mouth. Now they're getting it everything all the way down to the alveoli almost. So it works very well, and that's what you're going to see more use of because it enhances adherence in these patients. This was a big deal, getting them to use the steroids every day. We talked about the meter beta agonists, and we use them as needed, and then a couple of other things that we use, and I want to make sure you know when to use them and how to use them because they've asked questions about that also. So long-acting beta agonists once a day or maybe twice a day, because remember the short-acting beta agonists, you use them 4 times a day, maybe even 5 times a day, even more sometimes. Long-acting beta agonists don't have to be used in everyday asthma. They don't have to be used routinely. So there's a couple of indications, though, that we want to use long-acting beta agonists. One is if a patient has nocturnal asthma. If they have a lot of nocturnal symptoms, a lot of nocturnal asthma, if they take the short-acting beta agonist 9, 10 o'clock at night before they sleep, it's short-acting, so about 2 o'clock in the morning, 3 o'clock in the morning, they'll wake up now and they'll have, wheezing and cough. And they'll take another couple of puffs and then go to sleep and wake up in the morning. So what do you do? So these people, don't have any symptoms at night and they don't wake up. They take long-acting beta agonists. Also, for other purposes, for purposes that make sense, if a patient has a job, does a lot of public speaking, or cannot be taking the meter dose inhalers all the time, then a lawyer that has to do public speaking or something like that, that patient would probably benefit from long-acting beta agonists so they wouldn't have symptoms throughout the daytime. So those are the main reasons. The one that they may ask you is about nocturnal symptoms. How do we take care of, how do we treat nocturnal symptoms from asthma? The answer is give them long-acting beta agonists. Now, I will say long-acting beta agonists have been associated in some studies, although some people question these studies, that the people that use long-acting beta agonists, there were more deaths related to this category of patients, in patients using the long beta agonists. And some people said maybe it's because, it gives them a false sense of that they're getting better. And then they don't come to the ER until they're in pulsus paradoxicus and cyanotic. But nobody has really reevaluated these studies. The truth of the matter is use the short-acting beta agonists and only use the long-acting beta agonists when you need to. when the patient has especially symptoms at night. Chronic systemic steroids, what I mean by that is oral steroids. Oral. So now they're not only using meter-dosed inhaled steroids, right? They're using oral steroids, like 10 milligrams of prednisone a day, 20 milligrams of prednisone daily. Is only for a small percent of the population. These patients are called steroid-dependent asthmatic. Those patients are the most severe asthmatics. Those patients are always followed by pulmonary and asthma specialists. Because these patients are taking oral steroids every day, of course, you get systemic side effects from the oral steroids, like the osteoporosis and all that stuff, the blunting of growth in young patients. So it's devastating, so you never want to use these drugs unless you really have to. Now, I didn't tell you before, but meter-dose inhaled steroids, remember the ones that stay in the lung, they also have some systemic absorption. It's minimal, but it's there. So now studies are saying, yes, they get osteoporosis. It's not as bad as the systemic steroids, but they get it too. They get increased risk of cataracts too sometimes from just the inhaled steroids. So even those, if you could, forego those, you try to get rid of them. But those are the basics things to treat asthma. You can't really minimize the inhaled steroids, but they even have systemic absorption and side effects. Much more the chronic, the oral steroids. So those patients, they're very severe and should be followed with an asthma specialist, a pulmonary specialist. Now, the new kids on the block, now for about 8 years or so, maybe a little bit more, are these things called the leukotriene modifiers or leukotriene inhibitors. Not all of them inhibit leukotriene, but they modify leukotriene. Now, leukotriene is somewhere in that inflammatory cascade. Remember, asthma is an inflammatory disease, and leukotriene seems to be one of the things that precipitate this whole inflammatory process in the lungs. So we give them these medications called the leukotriene inhibitors, modifiers, in order to suppress this inflammatory process. Drugs like montelukast, and there's other ones too. They all work about the same. Now, these are great drugs in which patients that are taking systemic steroids, because those patients, if you give them leukotriene modifiers, you prevent, or you may prevent them from taking systemic steroids, or at least you have a chance of decreasing the amount of systemic steroids that they are taking. So for the boards, when should leukotriene modifiers be used in asthmatic patients? Not routinely. They're very expensive, and we still don't know, the side effects because they've been out there for a short time. When do we use them? The answer is use them in patients with steroid-dependent asthma in order to be able to try to get the patients off the steroids, or to at least minimize the dose of the steroids that you have to use in these patients. There have been some cases of leukotriene inhibitors associated with some vasculitis syndrome, like Sjögren-Strauss syndrome. Sjögren-Strauss is a vasculitis, just like polyarteritis nodosa, kind of like the same category, that affects the lung. Now, these patients commonly have asthma, they have IgE elevations, they have eosinophilia. So when these patients were given the leukotriene inhibitors, they developed Sjögren-Strauss syndrome. What most people think is there's not a direct association, meaning that montelukast or some other leukotriene inhibitor didn't induce Sjögren-Strauss in these patients. These patients had Sjögren-Strauss always. Why they developed Sjögren-Strauss now, when they took the leukotriene inhibitors, is because you pulled them off the steroids. Remember, that was the concept, to pull these patients off the steroids and give them only leukotriene inhibitors. So even though there's an association, you should use these medications in patients with the steroid-dependent asthma group. Cromolyn and natocromolyn are great medications. They are both mast cell stabilizers. They should not be used in the acute exacerbation. They may ask us, when Is it contraindicated to use cromolyn and natocromolyn? The answer is we don't use it in the acute exacerbation because it sometimes, paradoxically, provokes, worsens asthma exacerbation. So these drugs are only to be used in the chronic setting to prevent asthma exacerbations. They kind of take like the role of steroids, inhaled steroids, to prevent asthma exacerbation. It's another drug to use to prevent asthma exacerbation. We don't commonly use cromolyn, natocromolyn in adults. Why? Because generally speaking, adult asthma is more severe. Patients usually don't benefit from cromolyn and natocromolyn. You could use it, you could try using it, but you will see most of these patients won't benefit. Sometimes it's people with mild asthma, it's worth a trial. We use it more in kids because cromolyn and natocromolyn work very well in kids because kids, generally children, have a milder form of asthma. I mean across the board, when we take everybody across the board. And also because think about this, I just told you that even inhaled steroids, there's systemic absorption. So we never want to use these medications in children. We want to forego them as much as we can. So cromolyn and natocromolyn is the steroids, the inhaled steroids in childhood asthma. They're used exactly the same way to stabilize and prevent asthma exacerbations. They also may ask, can we use them in adults? Do you guys know of a case where natocromolyn and cromolyn is indicated? The answer is yeah, there is one case. There's a couple of cases. The most important one is exercise-induced asthma. In exercise-induced asthma, it's usually mild. And what do we tell the patients to do? Is take a couple shots of cromolyn before to prevent the exercise-induced asthma. That's one way to do it. There's also other ways, using a bronchodilator, but that is one indication to use cromolyn or natocromolyn in adults. We don't like to use catecholamines, epinephrine, and we don't use aminophylline and theophylline. So right here, these two groups of drugs, I put them in here so I could tell you, we don't use them. We may use them in status asthmaticus, but we don't routinely use them. That's the only time, and they're not going to ask you to manage a patient with status asthmaticus. We don't routinely use them in patients. Patients presenting with acute exacerbation, 90% of the time you could break the exacerbation with bronchodilators and the steroids. So please don't use epinephrine. Don't use aminophylline, theophylline. We may use them sometimes in COPD patients, theophylline, but we don't routinely use it in asthmatic patients. I know people do a lot of this, but you're not supposed to do it. It's contraindicated. I shouldn't say that. It's not contraindicated. It's contraindicated because you have just as good medication. It's not contraindicated in a way that it's going to cause side effects and something worse is going to happen to the patient. It's just not indicated because there's better medications, and 90+% of the time you break the exacerbation. So please don't use that. So a couple of things. You're going to see over the next couple of years, and in fact they're out already, some guidelines into how to manage patients with asthma in the outpatient setting. So these guidelines have gotten very convoluted. They've gotten very busy, those slides, and everybody gets confused now. So I'm going to give you my breakdown. They're modified. They're not exactly like the Thoracic Society's consensus, but just let me tell you, for the boards, they will take care of 100% of the cases on the boards. So just a couple things. So you break down asthma into 3 categories: mild asthma, moderate asthma, and then we have the severe asthma. This is the one that, they go in the hospital all the time and stuff like that, and then usually they're steroid dependent. So mild asthma means that this patient has less than 2 attacks per week. You ask them how many times a week, they say, okay, maybe once a week, maybe once every other week, at the most twice a week. So it's usually less than 2 times per week. That's minimum asthma. And they don't have a lot of night symptoms. So less than 2 a week, no night symptoms. In these patients, you only use albuterol. Remember I said, look, if you could even forego inhaled steroids, right? You don't use inhaled steroids because there's systemic absorption. There's minimal systemic absorption, but there is. Well, this is the group that you don't have to use it. People that have very mild symptoms, you say, okay, fine, let me just try the albuterol. And you tell them, whenever you get the attack, once a week or once every 2 weeks or once a month. Use the albuterol, and that's it. Now, a lot of these patients, they get an asthma attack once every year, once every 6 months. So it's not a big deal. Don't use in these patients the inhaled steroids. Unfortunately, most people that we see, maybe it's because we don't see these mild cases, but unfortunately, most of the cases that we see as physicians in the hospital, in the outpatient setting, fall into this category here, moderate asthma. That's what most people fit into this category, and some of them into severe asthma. So moderate asthma means that patients have symptoms most of the week, maybe daily, they may be mild, but they have it every day, and they always have night symptoms most of the days of the week. So this accounts for about 70–80% of the asthma that we see in adult medicine. Now, it's a skewed population because it's only people with symptoms that come to the doctor. People with mild asthma hardly ever go to the doctor. They take a little bit of inhaled albuterol. They never go to the doctor. So this is the reason, but this is the patients we see. And these patients now, you have to add the inhaled steroids. And you tell them, what do you have to take every day? The inhaled steroids. When do you take the albuterol? As needed, whenever you have the bronchoconstriction, whenever you have the wheezing. And that's it. They come into the hospital, they get treated for an acute exacerbation, you put them on a steroid spurt, you finish off after 14 days, they're back to their inhaled steroids and albuterol as needed. The third type is the severe form, and these patients, despite having inhaled steroids and albuterol on board, they have symptoms, and they have frequent hospitalizations. And a lot of these patients tell, yeah, when I was, 10 years ago, I got intubated in the hospital because I had severe asthma and so forth. And these are the patients that need regular treatment, right? So the regular treatment means this stuff here, the inhaled steroids and the albuterol. That's the regular treatment in asthma. So you have to have them on that. In fact, they have to be on that because that's what they failed. They failed that, but you have to keep that on board and then add on more medication. You don't stop the regular treatment. If you stop the regular treatment, then you have to use more of the bad medication, like the systemic steroids and stuff like that. So the regular treatment, and now plus you have to use a combination of other medications. These patients benefit from long-acting beta agonists because they have symptoms into the night all the time. So they can't sleep at night. You have to use long-acting beta agonists. They have symptoms in the daytime. So, they're working and they're coughing and they're wheezing all the time. So they have to use long-acting beta agonists in the daytime and a lot at nighttime. And then this is the group of patients, not all of them, but a good percent of them are steroid dependent, right here. So now you're going to say, okay, if my short-acting albuterol, my inhaled steroids, and my long-acting beta agonists are not working because this patient still has symptoms, then I have to add more medication. What medication do I add? Well, first line is anti-leukotriene drugs, right? Because you don't want to use systemic steroids. You use the systemic steroids last. If you've put the patient on everything and they still have symptoms, so they're on anti-leukotriene drugs, they're on long-acting beta agonists, they're taking the regular treatment, and they still have symptoms, only then do we decide to go to oral steroids because they have bad side effects, and now you got to use them for their whole life. If a patient already comes into your office and says, yeah, my doctor didn't tell me about anti-leukotriene drugs, but I take oral steroids and I'm taking long-acting beta agonists in my regular treatment, and, I feel good. What should you do? The answer is try to minimize their dose of oral steroids. If they're, for example, on 20 milligrams of steroids, start using leukotriene inhibitors to try to cut down their dose. That's not good for them. They'll develop osteoporosis, they'll develop other stuff. So that's the way we treat asthma. Please, know a little bit about mild versus moderate versus severe. If you know mild asthma, you know which patients shouldn't be, that's the most important one, shouldn't be on inhaled steroids. They'll just managed symptomatically with bronchodilators, like albuterol. So that's very good. So that's the treatment of outpatient asthma. So let's go back here. Let's go back here and let's do a couple cases and make sure we understand what we just talked about. And I'm going to give you a couple cases because they're very important to illustrate what we've learned in all the stuff that we learned about asthma. So we're going back to the first case we started off with. A 26-year-old woman with history of asthma presents to the emergency department with 3 days of progressive shortness of breath. She's taking inhaled albuterol and the over-the-counter cold medication. The respiratory rate is 28, pulse is 110, she's febrile. She's got the right nasal turbinate is edematous, so you think maybe that's a nasal polyp there, right? And this is why she's got this hypersensitivity to aspirin and NSAIDs. There's evidence of wheezing throughout both of her lungs. After you give her supplemental oxygen, what should we do next? What should we do next is the answer is give her short-acting albuterol, either by nebulizer or meter-dose inhaler. Because she looks pretty sick, I mean, from the history, I probably would go more with a nebulizer treatment to start off with. But then you could transition to a meter-dose inhaler in the hospital. Right away, you start her on steroids. Right away. Because remember, that's going to be the way to treat the inflammation. And I mean oral steroids or IV steroids. Some patients that are very sick, you only give them IV steroids, like IV methylprednisolone, or oral steroids, prednisone, which is just as good and it has the same efficacy, but the problem is sometimes very sick patients, short of breath, they can't take anything by mouth. They're too sick. So that's why a lot of people give everything IV, IV methylprednisolone, nebulizer, right? And they don't want to tire the patient out. But for your purpose, once the patient feels a little bit better, you could transition the IV corticosteroids to oral corticosteroids. How long are you going to give it to them for? It's a steroid spurt. So you give it to them 10 to 14 days and taper it off within that time. They shouldn't be taking it after 2 weeks unless they still have symptoms. Some people taper it off even quicker, 7 to 10 days. They're not going to ask you about what is the optimum time, but I'm just giving you an idea. It's usually 10 to 14 days that when the patient's tapered off that time, they feel better afterwards, and then you go back to their regular medication. Now, according to this patient, if you go back to her history here, look, she's only on inhaled albuterol, right? So she's only on inhaled albuterol, which means that she has, by definition, if they know what they're doing, whoever's taking care of her, that she has only mild asthma. So you want to go back and ask her, how many times you have an exacerbation of asthma? If yes, it's indeed less than twice, per week, yeah, then you keep her on the inhaled albuterol. If she says, no, lately, I've been having asthma exacerbation every couple of days, then this patient doesn't have mild asthma, now it has moderate asthma, and you need to add a steroid meter-dose inhaler to her regimen of inhaled albuterol. In the hospital, we have to do some more things, right? We have to get an ABG and make sure she's not hypercapnic. We have to get a chest x-ray to make sure she doesn't have infection in her lung. And we monitor her oxygenation with a pulse ox after we do the ABG. Most patients with asthma usually get better within a couple of days. And then after a couple of days, we'll send her home on her prednisone, her inhaled albuterol, and she will be followed up in clinic in about 2 weeks, right at the time where she's ready to be taken off the prednisone. So we see, is she doing well? Because if she's not doing well, we're not going to taper her off the prednisone. We'll continue for a couple of days more. If she's doing well, then in 2 weeks when she sees us in clinic, we stop the prednisone and continue, right, her regular treatment, whatever that may be. In this case, it was inhaled albuterol. We tell her to go see an ears, nose, and throat doctor to make sure she doesn't have nasal polyposis, right? And we make sure we talk to her about avoiding aspirin and nonsteroidals because they may be the precipitants in this case. This was a real case, and she had this triad of severe asthma exacerbations, nasal polyposis, and sensitivity to aspirin. The over-the-counter medications in this case had aspirin in them and nonsteroidals, so she was getting the asthma exacerbation. There are clinical signs and symptoms and laboratory findings that are associated with poor prognosis. And we talked about that, the cyanosis, right, the silent lung, the muscle retraction, and stuff like that. But I want you to compare, we're still on her case, her ABGs. Look at this to the left here, 7.32. That's less than 7.4, so that's acidemia. Her PCO2 is starting to increase, right? So she's getting hypercapnia. Her PaO2 is 60, but we don't care about that. But look, this we care about because it shows hypercapnia and respiratory acidosis versus this right here, where this patient, 7.45, has respiratory alkalosis, is blowing off CO2, 30, and her PaO2 is 50, right? It's less than this one here, but who cares? This patient is normal here, is doing fine, she's going to do better. If you get an ABG like this one here in an asthmatic patient, in our patient before, that patient needs to go to the ICU. May need intubation because of the things we said. In a patient with asthma, when you see respiratory acidosis or even looking anything close to respiratory acidosis and CO2 retention, you have to be very, very careful in these patients that they don't develop muscle fatigue and then, you know, they'll go bad in front of your eyes. Her discharge medications, remember what we said? What are her discharge medications? Albuterol, inhaled steroids. This is the usual treatment of asthma, in most cases, right? And then a tapering dose of oral steroids. Now our patient, I think she was taking only albuterol. So whatever her usual medications are, okay? And then you ask her, about symptoms and stuff like that. Maybe you need to use inhaled steroids in the long run in the first place. But the point to be making here is she's going to be on a tapering dose of oral steroids, and then she comes to see you in about 10 to 14 days. Okay? And then after she's doing well, then you keep her on her stable, her usual medications, albuterol and inhaled steroids. And then she takes that, for the rest of the time. Going forward with a couple more cases on asthma and illustrating some of the points why we have to do a couple of things that we talked about, and also looking into some of the cases that look like asthma but are not the typical asthma. We're gonna look at these now. A 32-year-old man with history of asthma comes to you for evaluation of moderate to severe asthma. He takes inhaled fluticasone, so that's a inhaled steroid, inhaled salmeterol, that's a beta agonist, right? And that's a long-acting beta agonist, salmeterol, and albuterol for breakthrough symptoms. So he's taking a short-acting albuterol, he's taking fluticasone every day, and inhaled salmeterol, long-acting. And he's got moderate to severe asthma, which so far this makes all sense. His physical exam disclosed a left nasal polyp and mild expiratory wheezing. So what does this guy have? And they ask us, what do we do about this guy? Well, we tell him to avoid taking aspirin and avoid nonsteroidal anti-inflammatory drugs. This is the typical case of the triad: asthma and aspirin sensitivity and nasal polyposis. A 22-year-old woman with no prior medical history comes for the evaluation of cough during the night. She reports a dry cough that wakes her up during the night 3 to 4 times per week for 4 months. She does not have postnasal drip, heartburn, morning hoarseness, or halitosis. That's bad breath. So right away, those are the questions you ask in evaluating a person with nocturnal cough, because some of the most common causes of this is postnasal drip. Postnasal drip is probably the most common cause of cough. Heartburn, morning hoarseness, and stuff like that associated with GERD, reflux disease, gastroesophageal reflux disease. That's also very common, second after postnasal drip. And they also tell you that a 4-week trial of omeprazole has not improved her symptoms. So right away, what do you do with this patient? Well, I said there is a variant of asthma that occurs at night. And you have to think about it in young people, because this patient, if you wanted to see what she has and document it and then treat it, you would send her for a pulmonary function test. And this would document that she has reversible obstruction, which is the definition of asthma, and then you would treat her with a bronchodilator before she goes to sleep at night, preferably because she has mostly night symptoms. You would give her a long-acting beta agonist to resolve the symptoms. So please look for this case. This is a very common scenario in clinical medicine. A 28-year-old woman reports episodes of coughing after she completes her 2-mile run. She has also experienced similar symptoms when she is exposed to cold weather. So now you're getting a different picture. She's coughing again, but now it's with exercise and cold weather. Her primary care physician was concerned about exercise-induced asthma, but her PFTs, her pulmonary function tests, were normal. The physical exam is unremarkable. What do you do now? Well, the pulmonary function tests are normal, but they should be normal sometimes, or are normal sometimes in patients with asthma, because we said this is 100% reversible disease. So what do you do now in this patient? You repeat pulmonary function test along with a methacholine challenge test to provoke bronchoconstriction in these patients, and that's the way you diagnose asthma. So when do we do the methacholine challenge test? In patients that we think have asthma, we get the pulmonary function test, they're normal. What do? We bronchoprovoke them with methacholine, with a methacholine challenge, and that's the way to diagnose asthma in those cases. So the answer here would be, what would be the next appropriate test in this case is to do the pulmonary function test with methacholine challenge. That's the right answer. A 42-year-old woman comes for the evaluation of wheezing, off and on for the past year. She reports a dry cough along with the wheezing, but feels otherwise well. She was a 20-pack-year history smoker and quit 12 months ago. The exam is significant for mild expiratory wheezing throughout both lungs. PFTs show an obstructive pattern with a decreased DLCO. So this is a red flag. So right away, this is why you have to do pulmonary function test in patients for presumed asthma. She came to you with wheezing, and if you go back to history, this is a true case. This woman was carrying the diagnosis of new onset asthma, and it could sometimes occur even in 40 years and 50 years, and she was carrying the diagnosis of asthma all this time. But when we did pulmonary function tests, we found an obstructive pattern that's consistent with asthma, but we found the DLCO decreased, and that's not consistent with asthma, because that means that the diffusing capacity, there's something wrong with the diffusing capacity across the alveolar membrane. That's not characteristic of asthma. That's more characteristic of emphysema. And what I did in this patient is we gave her a bronchodilator, and she did not reverse. There was no reversibility. So she has emphysema. A 42-year-old woman with emphysema, well, she's a smoker, but why did she get, why did she get emphysema so early at 42 years of age? Generally, most patients have a smoking history, and they've been smoking for 30 plus years, and then in the 6th or 7th decade of life, they tend to develop chronic obstructive lung disease. So the thing to think about here is to, alternative diseases that cause emphysema early on, like alpha-1 antitrypsin deficiency and so forth. So this patient had actually alpha-1 antitrypsin deficiency. A 27-year-old man with asthma comes to the clinic for evaluation. He has symptoms of asthma almost every day and has been to the ED, the emergency department, 2 times over the past 6 months. So right away, your history here is one of severe asthma. He uses inhaled albuterol over 5 times a day to control symptoms. He also takes inhaled triamcinolone, that's an inhaled steroid, and prednisone. So this is oral prednisone, 20 milligrams a day. So he is a steroid-dependent asthma. His exam is significant for diffuse wheezing. So the question in this guy is, what do you do? What's the big deal here? Why are they giving us this history? The answer is, well, maybe we could use some kind of medication in a 27-year-old steroid-dependent asthmatic to reduce the use of prednisone, at least minimize it, if not, to basically do away with it. And the answer is, what do we do next in this patient? At least try to use leukotriene inhibitors in this patient, like montelukast to be able to take the patient off the prednisone. That's the exact scenario where I told you, look, you know, this guy needs montelukast to be able to get him off the prednisone. And now look what the other thing here, he uses inhaled albuterol over 5 times a day to control symptoms. So can you use any other type of bronchodilator for this patient to be able, for him not to, you know, get some relief from the wheezing and stuff like that and not use this drug 5 times a day? The answer is yeah, put him on long-acting beta agonists. So the answer in this patient would be put this patient on leukotriene inhibitors. That's the most important thing, to try to get him off the prednisone. And then number 2, put him on long-acting beta agonists to be able to have some minimization of symptoms. So that's a nice case. A 38-year-old man with asthma since childhood comes because he has been wheezing during the night. His daytime asthma symptoms are usually active 4 to 5 times out of the week, but takes inhaled albuterol and inhaled beclomethasone. So he's taking inhaled albuterol, he's taking beclomethasone. His daytime asthma symptoms are usually 4 to 5 times a week. He has no symptoms during the day, but wakes up at night 1 to 2 times in order to use the albuterol. This occurs most of the week. So what's the next treatment in this patient since he has mostly nocturnal symptoms? The answer is give him long-acting beta agonists. Remember, I told you beta agonists, we don't have to use it in everybody. It's only certain cases. This is one, and the prior case where the patient has symptoms throughout the day. So the right answer here would be to use that, and then to ask yourself, you know, why does he have, you know, wheezing during only at night? And I said there's a variant of asthma. Asthma actually in a lot of people is worse at night. They have a lot of nocturnal symptoms during the night, and there's a lot of theories, as we said, but the bottom line is a lot of them have worse symptoms. But you have to ask yourself, maybe this guy has asthma and has reflux. The reflux, he refluxes into his lung and actually getting worse, makes his asthma even worse. So treating and looking for stuff like that, like reflux disease, you know, takes you a long way in these patients. So the answer here would be use a long-acting beta agonist in this patient and look for some diseases that may precipitate asthma, like postnasal drip, like reflux disease, and treat those. A 26-year-old woman with history of asthma will be admitted to the hospital because of an asthma exacerbation. Her chest x-rays show hyperinflated lungs and flattened diaphragms, but no infiltrate. Her ABG is 7.2, so that's less than 7.4. She's acidemic. Her CO2, significant CO2 retention above 40. You're the admitting physician in the emergency department and have to make a decision on the level of care. What do we do about deciding where this patient is going to go? Right away, the ABG tells you here, look at this patient has hypercapnia, right? What do we do in this patient? We admit him to the ICU because this patient may get intubated in the short future. So here I want to show you, so if you remember this case where the patient is acidemic and hypercapnic with asthma, you remember this chest x-ray. I want to point out a couple things right away. You know, look at this. We put her straight in the telemetry bed because, right, you could see the all the monitored stuff and things like that, and so forth, and you could see the flattened diaphragmatic surfaces right here, and you could see the hyperinflated lungs and so forth. So this patient, the x-ray doesn't tell me anything really. It just, the ABG is the most significant part of this that tells me I need to put this patient in the unit and maybe intubate. A 22-year-old woman with asthma is admitted to the hospital for asthma exacerbation. Her asthma has taken a turn for the worst over the past few months. Her chest x-ray show bilateral upper lobe infiltrates. Her total serum IgE is elevated. Eosinophilia is present. A cutaneous reactivity test, also called a prick test, is positive for aspergillus. Aspergillus antibodies, IgG, are positive in the serum. So this case started off and as an asthma exacerbation, right? An asthma, a case of a person having asthma that took a turn for the worse. But what you've noticed is a couple things more. Not only all of a sudden it took a turn for the worse, but she has X-ray findings, bilateral upper lobe infiltrates. Now the IgG is elevated, you can find that in asthma. Eosinophilia is sometimes present in asthma. That this is new for this patient. And you noticed also they did the right test in this patient and look for aspergillus. Now what this patient has is a very, very interesting syndrome. It's called allergic bronchopulmonary aspergillosis. Now ABPA, allergic bronchopulmonary aspergillosis, is not an invasive aspergillus infection in the lung. These patients have aspergillus in the lung, but they have like an allergic reaction of the lung to the aspergillus, and it gets their asthma worse. What do you have to do in these patients? You have to treat them with high doses of steroids. That's how they get better. So again, let me say this. Patients with asthma or something that looks like asthma, and they have infiltrates in their lungs, and their IgE is elevated, and they have eosinophilia, or they have asthma in the past, and now it gets worse, and they have upper lobe infiltrates or lung infiltrates, think about allergic bronchopulmonary aspergillosis. The test to do is to do a prick test. It's a cutaneous reactivity test on the skin that becomes positive for aspergillus, and then confirm with the aspergillus antibodies. This disease is called ABPA, allergic bronchopulmonary aspergillosis, and we treat it with steroids. You're going to hear a lot about this disease in the next couple of years or so. A 20-year-old woman with new onset asthma is admitted to the hospital for asthma exacerbation. 2 months prior to this, serum IgE and eosinophils were both elevated. The chest x-ray on admission shows multiple infiltrates. Creatinine is elevated, and urinalysis shows red blood cells and protein. So right away, a kind of like one of the other ominous or red light things that I look for in asthma is there organ involvement is there organ involvement beyond the lung? And what I see here is that she has some renal failure. Her creatinine is elevated. Her urinalysis shows RBCs, so active sediment, and protein. And I say, wait a second, why would an asthma patient have this? Unless we're using some renotoxic medication, it shouldn't be the case. Most inhaled steroids and most inhaled beta agonists and stuff like that really don't affect the kidney. So I have to think about a disease that looks like asthma or has asthma as part of the disease, and also may affect the kidney. And one of the diseases that you should think about, that's what this patient had. She has Churg-Strauss syndrome, a type of vasculitis. These patients have a vasculitis. It involves the lung, and then these patients have also asthma and IgE and IgE elevation and eosinophils in the blood. But now they have other systemic manifestations, like, for example, mononeuritis. They have kidney involvement. They may have abdominal involvement. They may have CNS involvement. So look for that evidence of organ involvement other than the lung, systemic involvement in patients with asthma. Think about other syndromes. Make sure you have the right diagnosis, or make sure you don't have Churg-Strauss syndrome, which is a vasculitis, and those patients actually do have asthma. Remember I said before that some of these patients, when they're giving leukotriene inhibitors, they get the full-blown Churg-Strauss syndrome. Well, they get the full-blown Churg-Strauss syndrome not because of the leukotriene inhibitor, but because probably we pull them off the steroids when we give them the leukotriene inhibitor or the leukotriene modifier. A 60-year-old man is brought to the emergency department with fever and cough over 3 or 4 days. His medical history is significant for hypertension, dyslipidemia, and CVA. He has 40-pack years smoking history. He takes atorvastatin, hydrochlorothiazide, lisinopril, dilantin, and aspirin. When examining him, you find right lower lobe wheezing. So, again, be careful when you look at patients with, that you kind of tend to think that all wheezing is asthma. This patient, of course, doesn't have asthma. First of all, he's 60 years old. He doesn't have the diagnosis. Yes, you could have new onset asthma in a 60-year-old patient. We said that. But look at this. Right here, you find lower lobe wheezing, right? Lower lobe wheezing right here. Not diffuse wheezing. That's not the typical finding in asthma. So another thing, you should see in the history that this guy takes Dilantin for seizures. So one of the things that you could get is you could get aspiration or foreign object, and basically it goes down into the bronchus and obstructs as a ball valve mechanism, part of the bronchus, and you have wheezing. So foreign object, aspiration, and stuff like that could have localized wheezing.